Good evening, everyone, and thank you for joining us here at the Core Institute as we discuss the latest advancements in treating hip and knee arthritis. Before we get started, I would like to share with you a quick tip on how to engage with us throughout the presentation. We know you may have questions during the presentation, so please use the Q&A feature at the bottom of the screen to submit your questions. We will have a Q&A session afterward to answer all of them. Now, it's my pleasure to introduce our very own Dr. Stephen Myerthall of the Core Institute. Dr. Myerthall is an internationally fellowship-trained and board-certified orthopedic surgeon specializing in hip and knee arthritis as well as hip and knee replacement.
I'm a Canadian. I was raised in Canada. I grew up in Vancouver. Canadians are really interesting people and good people. They're the only people in the world that have actually named a beer after themselves. If there's any Canadians out there who are hockey fans, like most of us are, you'll notice that this is probably the second most famous goal in Canadian hockey history. This, of course, happened in the 2010 Olympics, which were held in my hometown, and this is Sidney Crosby scoring the overtime goal against the Americans to win the gold medal. Although this is one of the latest pictures of me. This picture is about 2 years old, and this is me the picture was taken at the Sandra Day O'Connor Courthouse downtown, and this was me receiving my American citizenship, and it was in May of 2018. So I guess I'm going to have to change my introductory slide because I'm now an American and no longer a Canadian. As I mentioned, I grew up in Vancouver, the host city of the 2010 Olympics, and I attended the University of British Columbia for many, many years. The picture in the middle there is, in fact, the University of British Columbia. And for those of you who are familiar with Vancouver, even those of you who aren't, the University of British Columbia is located out on a point by itself, and it's separated from the main city by an area that's called the endowment lands, that is government-owned lands that they can't develop on. So when you get out to the campus, even though it's in a major metropolitan city, you very much feel like you're in a college town out there. There's nothing really out there but the university and the facilities that support the university. After I completed medical school, I went on to do my residency at the University of Toronto. I was there for 6 years as an orthopedic resident, and then when I finished, I decided to stay on for an extra year, and I did my fellowship with a surgeon named Alan Gross, who's very famous in the orthopedic world. This is a really interesting picture. This is what's called Hospital Row in downtown Toronto. The picture was taken from the lawn of the Sick Children's Hospital, which is a world-renowned hospital for the care of children. The buildings on the left from the bottom of the screen to the top are the Queen Elizabeth Rehab Hospital, a huge hospital in downtown Toronto. The second one is the Mount Sinai Hospital, which was where I actually did my fellowship. And then just above that is the Princess Margaret Hospital, which is the largest cancer hospital in Canada. On the right-hand side, you can just see a building that's poking out from behind the tree there. That's actually part of the Toronto General Hospital, which is a really well-known hospital also. And if there's any diabetics that are out in the crowd tonight, part of the Toronto General Hospital is the Banting and Best Institute, which was where insulin was first discovered in the cure of diabetes. Now, the most interesting picture, or the most interesting building in this picture, I think, is at the very top. That sort of Gothic-looking building that you can see is actually the Houses of Parliament for the province of Ontario. And it's really interesting, I think, when you compare the medical system in Canada to that in the United States. Here's the largest area of condensed hospitals in Canada, and right above it is the Houses of Parliament. And it sort of symbolizes the role that the government plays in the medical care in Canada. So after I finished my fellowship, I came to Phoenix. I practiced for 3 years before I joined CORE, and I've been a member of the CORE Institute now for 15 years. The CORE Institute is the largest orthopedic practice in the state of Arizona. This is just a graphic map of the city of Phoenix, and it shows that we have multiple clinics, in fact 8 of them spread out throughout the valley. We have 3 spine centers throughout the valley as well, 7 physical therapy clinics, and right there in the middle of the picture with the green balloon is meant to represent the CORE Institute Specialty Hospital. This is an orthopedic-only hospital where we do the majority of our surgeries, and I'll talk a little bit about that further on in my talk. Now, I would be amiss at this time if I didn't mention what safety protocols we at CORE here are undertaking during this time of COVID-19 in order to make sure that our staff and more importantly, or most importantly, our patients are safe when they come to us for the care of their orthopedic problems. We recently instituted telehealth and teletherapy. So if you're not feeling well, if you're at home, you want to come and see your doctor, you have some questions about your doctor, you're somewhat apprehensive about going out during this time of uncertainty with COVID-19, we would encourage you and let you know that we do have the capability to do consultations with you via telehealth and telemedicine. The other things that we're doing in the clinic itself, we've increased our sanitization protocols. We wipe down countertops, we wipe down doorknobs frequently throughout the day. We've also spaced out our waiting room so that there's less chairs there and people aren't exactly sitting necessarily side by side and are practicing social distancing. The other thing we do at our clinics and our hospital is that all staff have a test when they come in. They take our temperatures and make sure that we don't have a fever. They also ask us a series of questions about whether or not we have a cough or any symptoms that are associated with COVID, and we do that for our patients as well. Furthermore, all of our staff are tested every 2 weeks for the antibody test for COVID-19, and if you were to test positive, you would be, depending upon what type of result it was, you would either be asked to go home or we would do further tests to make sure that you weren't shedding any virus at the time. I would also like to mention what you can do for us during this time, and we would ask that when you're in our clinic or in our hospital that you wear a mask, that you limit the number of visitors that you bring with you. There are a certain number of people that need to have translators in the room when they meet with the doctor. People like to have their caregiver there as well, but we're asking people not to bring children and so on into the clinics when they're coming for their appointment. And most importantly, and our staff have this message as well, that if you're not feeling well, stay at home, call the clinic, reschedule your appointment. We'd be glad to see you at another time. So I'm going to delve into the topic of our conversation this evening and talk a little bit about arthritis. Before doing so, I have a quiz for everybody out there. Any Star Wars fans or people who have just seen some Star Wars movies, I want you to think who the only character to appear in all the Star Wars movies to date is. And I'll give you the answer at the end of my talk. So Van C. Mao, who used to be the chairman of the Orthopedic Research Society and is well known for his work on cartilage research, once stated that the human joint functions so well that we're totally unaware of it until there's a problem. And if you think about that, it's true. In our daily lives, and especially when we're younger, we can walk around, we can run, we can do all sorts of activities. We never have to think where our legs are in space. We never have to look and actually think when our foot hits the ground. We know this because our joints work that way and they give our brain information about where they are. But when you get older and you start to develop arthritis, and I can speak personally for this, you know where your knee is on every single step that you take. So arthritis itself is the loss of articular cartilage. Now what articular cartilage is the cartilage that lines the end of the bones where there's a joint made. And I'm sure a lot of people out there are fans of chicken drumsticks. If you ever look at the end of the chicken drumstick, after you've taken all the meat off of it, there's like a shiny blue cap on the end. That is exactly what articular cartilage is. So when you lose the articular cartilage and part of the disease process, what happens is it exposes what we call the subchondral bone. Sub meaning below, chondral meaning cartilage. It exposes the bone that's underneath the cartilage. Now it's an interesting phenomenon that cartilage has no nerve endings. So as the cartilage is being deteriorated and worn away, it's not painful. However, bone does have nerve endings. So once the bone is exposed, the nerve endings are exposed, and that's what creates pain. The body's response to this is to lay down bone spurs, what we refer to as osteophytes. And you can see those on the diagram. They occur at the edges of the joint. Now the problem is, those don't have cartilage on them, so they don't function well. They tend to be very irregular in shape, and they tend to cause pain when they rub up against the capsule and the other soft tissues that are in the joint. Another thing that commonly happens with arthritis is that you end up with deformity of the joint, and that occurs when there's uneven loss of cartilage between one side of the joint and the other, and I'll show you that later on in one of the x-rays that I'm going to show. The hallmark that you will experience when you have arthritis in your joint is that you will experience pain, and it will be the pain that will make you want to seek out the care of your physician and ultimately end you up in my office talking about surgery. So what kind of things cause arthritis? Well, trauma can cause arthritis. For instance, if you have a fracture, particularly a fracture that goes through the joint and into that articular cartilage that I mentioned, it's very difficult for surgeons who treat trauma patients to get that joint perfectly aligned. If the joint's not aligned, it doesn't articulate with the other side of the joint well, and it can go on and cause arthritis. Another type of injury that can cause it is ligament injury. You know, you hear about athletes who end up with anterior cruciate ligament injuries, for instance, in the knee. And even though we as orthopedic surgeons have learned how to reconstruct that, we can never reconstruct it to how nature had it work in the first place. And what we often see with athletes later on in their lifetime is that they develop arthritis of the knee. Prior surgery that you may have had, meniscectomy for instance. I think in Canada the most famous athlete to have meniscal surgery in the 60s was Bobby Orr, who was a hockey player. But in the United States, the most famous athlete was probably Joe Namath. And back in the 60s and 70s, when athletes presented with meniscal tears, the orthopedic surgeons went in and completely took out all of the meniscus. And ultimately what happened is these individuals progressed through their life and used their joints to walk or to run or to do the activities that they wanted to. The meniscus didn't serve its function because it wasn't there. This led to breakdown of the cartilage and ultimately to arthritis. There is, of course, some genetic predisposition to arthritis, although science has yet to prove what that is. Often we see multiple members of families who come in with arthritis, or will come in with the story that my mother has arthritis and she had her hips replaced when she was still alive, and my sisters have it. But there's always a member of the family that doesn't have it, which doesn't necessarily fit into a genetic pattern. Inflammatory arthritis, the most common being rheumatoid arthritis, is also another mechanism that causes arthritis. Avascular necrosis, which avascular meaning without blood, necrosis meaning death, is what happens to bone when for whatever reason the blood supply is cut off. Some of the causes of that again include trauma. Others include taking oral steroids for things like transplant surgery, for instance. People who have had transplants, they tend to take steroids, and it ultimately can lead to an interruption of the blood supply to the bone. Now, the places that it occurs most frequently is in that subchondral bone, which sits right below the cartilage. So the cartilage is the cap to the subchondral bone. But if the subchondral bone dies, it collapses. There's no longer anything supporting the cartilage, and ultimately what happens is the cartilage breaks down and you end up with arthritis. There's also congenital or growth problems that can occur, but by far and away, the single biggest cause of arthritis is aging. It's what I refer to my patients as that general wear and tear arthritis. You know, if you look back hundreds and hundreds of years, the human species did not live as long as we live right now. And ultimately what happens with us, with our longevity, is that we outlive our joints and the cartilage wears out and we end up with arthritis. Some of the other factors that we can talk about include obesity, injury to the joint, loss of joint stability, which I mentioned, or trauma. Those types of things cause abnormal stresses on the joint. Aging, growth, or metabolic diseases can cause abnormal cartilage, as can inflammation or immune-mediated responses such as that which we see in rheumatoid arthritis. Ultimately, what happens with the abnormal stresses and the abnormal cartilage is the cartilage itself becomes compromised. It can become compromised structurally, or it can become compromised with regards to the biochemical makeup of the cartilage itself, which ultimately leads to cartilage breakdown. Here we have two arthroscopy pictures. I'm not sure where we got the one on the left from of a healthy knee, but that's what a healthy knee looks like. If you look at the top, the semicircle that you see there that's white is the end of the femur and the cartilage is visible. At the bottom, the flat white pan is the top of the tibia, and the meniscus is the sort of wedge-shaped structure that sits between them. On the other hand, on the right, we see what's an arthritic knee. Now, once you get down to an arthritic knee, as I mentioned, the cartilage breaks down. You can see areas where the subchondral bone is exposed, both on the tibia and on the femur. And you can see that the meniscus looks like it's been chewed up and is sort of just irregular in its shape. Doesn't have the sharp edge like it does on the picture on your left. So we know from the census in 2010 that at that point in time, there were more people over 65 years of age in the United States than teenagers, and this was the first time that that had been recorded. Baby boomers turn 50 every 7.5 seconds. That means that you can see the number 1,200 baby boomers turn 50 every day. And another study from the Arthritis Society showed that the prevalence of arthritis is higher in women at almost 26% than it is in men. This is an old slide that showed the numbers of people with knee arthritis in the United States. In 1995, it was 40 million, while in 2002 it had expanded to 59 million. I'm not sure what the numbers are now, but I can guarantee you it's much larger than 59 million. So what do we do to treat osteoarthritis? Well, there's always the non-surgical options, and we always like to start with the non-surgical options. Now, by the time you get to my office, you may have already been through these, as most primary care doctors will start their patients out on this. But these include things like activity modification. As you can see lower down there, we like to do low impact exercise versus jumping exercises, as it puts much less stress on the joint. If necessary, we like to have our patients utilize walking aids such as a cane, because you can offset some of the stresses that are placed through your joints by utilizing essentially your arms to to hold a walking aid and ultimately support your walk when you're walking. And finally, we like to talk about issues such as weight control. Now, clearly that's a problem in our society. We do have a lot of people who are overweight, and by controlling your weight, it decreases the amount of stress that's placed through your joints and ultimately should decrease some of the pain. The changes that we have with arthritis, however, I want to let you know are irreversible. So if you develop arthritis with loss of the cartilage, you're essentially treating the symptoms by losing weight or doing some of these other non-operative options. You will never be able to restore that cartilage that's there. Some of the other non-surgical options include a medication, treat patients with things like Tylenol or non-steroidal anti-inflammatories such as Motrin, Aleve, ibuprofen, topical ointments such as heat liniments, or we can even apply the non-steroidal anti-inflammatories topically that way. Glucosamine and chondroitin sulfate, which are derivatives of shark cartilage, which are also present in human cartilage. You can buy these at most vitamin stores and in fact most drugstores. And then there's also oral steroids, which we can put people on for short term to see if we can decrease some of the inflammation. In terms of other non-surgical options, there's injections. And again, rather than give people oral steroids that tend to affect them systemically, we can inject Kenalog or Marcaine or Kenalog or cortisone, one of those corticosteroids, directly into the joint to get a much higher concentration delivered locally. There's also a method called viscosupplementation, and most people know this as either gel injections or the chicken or rooster comb injections. It's really an interesting story how people refer to this and how and why people refer to this as the coxcomb injection. So all of our joints contain synovial fluid, and it's secreted into the joint by the lining of the joint and the synovial cells. This includes all of the small joints of our hands, our hips, our shoulders, and our knees, every joint in our body. Now, scientists discovered many, many years ago that if you crush the rooster comb, what it does is it also secretes synovial fluid. But the thing about it is it secretes a much younger person's type of synovial fluid in that it's very rich in proteins and proteoglycans and sugars and other stuff like that that our joints need. So fortunately, we don't have to go out and kill roosters anymore in order to treat our arthritic joints. We're now able to synthesize this in the lab. Now, we currently use a derivative of the viscosupplementation that's known as Durolane. And Durolane is a single injection that seems to have the best results according to the literature. There are other types of injections that are out there on the market that will involve a series of injections, some including 2, 3, or even 5 injections. Now, the other thing to bring to your attention is that currently this is only FDA approved for treatment of knee arthritis. So if you were to present to the office with hip arthritis, we'd be unable to offer this treatment for you, but definitely for people with knee arthritis. Once we get onto the surgical options of the treatment of arthritis, these include arthroscopy of the knee, where we put a fiber optic camera into the knee and also place other instruments which we can go in and clean up some of the arthritis or the tears, like for instance in the arthroscopy picture that I showed you earlier. There's also cartilage transplant. This generally is only available for younger people because once deformity sets in, we can't take cartilage either from one part of your joint to put it in an area where the cartilage is absent, or we can't take cartilage from a donor, such as people who donate their hearts and their lungs and their kidneys for other people can also donate their joints, believe it or not, or at least portions of their joints, but that tends to be done for younger patients. And osteotomy means to cut the bone, and what we can do there is we can make cuts and take out wedges of bone around the knee or the hip to redirect the way the forces are transmitted through that joint so that the injured part of the joint or the arthritic part of the joint doesn't see as much stress as the uninjured part. By far and away, the biggest surgical advancement in the treatment of osteoarthritis, however, is joint replacement surgery. So that's what we'll be talking about now. So what is joint replacement surgery? Again, it's the treatment of arthritic or damaged joints after failure of non-operative measurements. What we do is we replace the diseased cartilage with a combination of metals, ceramics, and plastics. As it pertains to the knee, and you'll hear me talk about this later on, in patients that have unicompartmental disease, that means only one part of the joint is affected, we can do partial joint replacements. However, in individuals who have multi-compartmental disease, we generally have to do total joint replacements in which all 3 compartments of the knee are replaced. So here's an x-ray, or 2 x-rays actually, of knee arthritis. The x-ray on your right is a normal knee. I always tell my patients that x-rays only show bone, they don't show cartilage. So when you see that black space between the 2 bones of the knee, that's not an actual void or space, that is filled with cartilage. What happens is the cartilage allows the x-ray beam to pass through it where the bone doesn't. It then marks the x-ray film that's on the other end, and when you develop the film, this is the picture you get. The picture on your left, however, shows clearly an arthritic knee, and you can see the difference between the arthritic knee and the healthy knee. On the left-hand side of the knee, it's bone rubbing on bone. There's no cartilage there anymore. If you look at the angle between the 2 bones, the femur on the top and the tibia on the bottom, they look relatively straight on the x-ray on the right, but they're curved, forming a sort of gentle C on the left-hand x-ray. There's also some cysts that are evident in there that are kind of hard to point out, but they're there, and you see those also with arthritis, and you don't see those in normal joints, in normal x-rays. The treatment, total knee replacement. Here's 2 x-rays, one from the front and one from the side of the same patient that shows a total knee replacement, and this is a postoperative x-ray. So those white circles that you can see at the front of the knee are the staples that we use to close the wounds after surgery. Here, as I mentioned, if it's only part of the knee that's affected, then we perform a partial knee replacement. For an orthopedic surgeon, the knee is composed of 3 separate joints. There's the part of the joint on the inner side of the knee, which we refer to as the medial compartment, And the first x-ray on the left there shows a medial unicompartmental arthroplasty. On the outer side of the knee is the lateral compartment, and there you see an x-ray showing a lateral compartmental arthroplasty. And the third compartment of the knee is the patellofemoral joint. That's the joint that's created between your kneecap and the femur that allows us to flex and extend our knees and create the power that's necessary to propel us. That x-ray shows an isolated patellofemoral arthroplasty. Hip arthritis, on the other hand, it's very similar. We see loss of the articular cartilage. Here, if you look at the x-ray on your left, it shows a pelvis. Now, I chose this x-ray because the hip on the left-hand side of that is a normal hip. The joint space between the femur and the bony socket on the pelvis is maintained, whereas on the right-hand side, the cartilage is lost, the joint space is lost. You can see here in the femoral head that there are black sort of oval or circular spaces that are rimmed in white bone. Well, those are cysts. Those are just fluid-filled cavities that can occur on either side of the joint as a result of arthritis. And the treatment of that is total hip replacement. And here's two views of the same hip, one taken from the front and one taken from the side of a total hip replacement. So we'll talk a little bit now about the advancements that have been made in total joint replacement. When I first started training, which seems like many, many years ago, well, it is many, many years ago. It's about almost 30 years ago when I started my training. We used what we call traditional instrumentation, and I'll go into that in a little bit here. But the goals of treatment for joint replacement surgery early on, when joint replacement surgery was first introduced, were to relieve pain and improve function. So how was it done from a traditional technique? I like this slide because it shows graphically some of the instruments that we actually use during surgery. We use saws, we use planes, we use hammers and chisels. An orthopedic surgeon is really just a carpenter, but rather than working with wood, we work with bone. This shows modern day instrumentation and the number of trays that are necessary to perform a surgical procedure like a total knee replacement. There are numbers of different sizes, which is why you see those discs that are different colors. I also always like to show this slide. I was fortunate many years ago, not many years ago, about 4 or 5 years ago now, to travel to Hanoi in Vietnam to help them introduce a new surgical technique over there. And it was really interesting. In the operating room, the nurse would just come in and dump out this basket of instruments onto the back table where the other nurses had to sort through them. Not quite as organized as we are over here in America. So again, traditional instrumentation. Essentially what we did was we took a rod and we made a little hole in the end of the bone and we passed the rod up into the bone. And on the end of that rod, we placed a variable number of guides and cutting blocks in order to allow us to cut the femur to fit the shape of the implant. Surgeons at that time very much relied on their eye to determine whether things were parallel and whether they were aligned correctly. So, how good was traditional total knee replacement? Well, considering the elementary introduction of the instruments that were used, we had pretty good results. 92% of patients would report good to excellent results 8 to 10 years after surgery. However, when we critically looked at these, we found that only 70% of the knees that were performed were accurate in terms of the positioning of the implants. And by accurate, I mean within plus or minus 3 degrees of the intended position that you wanted to put the implant in. Also, none of them last as long as we would wish. That comes from both the patient perspective and also from the surgeon perspective. We want these implants to last as long as possible. Most of our patients want them to last the rest of their lives. And as a surgeon, I'd also like it to last the rest of your life, because sometimes going back to do a revision surgery or to take out the first implants and implant new implants is not necessarily the easiest thing that I do in my day. We also found that 5 to 8% of these knees failed early. And by early, I mean within 2 years of their initial implantation, and they usually failed secondary to poor balance of the joint and also poor alignments of the implants. Now, balancing a joint is a concept that I'm going to talk about later, but it's important that the joint be balanced. And by that, what I mean is if, for instance, if you look at this x-ray and you look at the inner and the outer side of the knee, the medial and the lateral side, which I defined earlier, you want to make sure that the space between the metal implants is the same on both sides. Otherwise, the joint is unbalanced. And if the joint is unbalanced, they will have unbalanced wear, and the joint will wear away quicker on the side that is tighter. Now, I should just go back to this x-ray again on the left there of the total knee replacement. It looks as though there's a space between the implants, but much like the description that I gave you for a normal knee x-ray, there's no actual space there. That's where the that's where the plastic buffer sits, and essentially what happens is the upper component rotates over the lower component. So how good were we at traditional total hip arthroplasty? Well, we were even better at total hip arthroplasty than we were at total knee arthroplasty utilizing traditional instrumentation. Greater than 95% of people would report good to excellent results at 8 to 10 years. However, the accuracy was also not as good. Only 80% of our implants were placed accurately, and we ended up with patients that would end up having a leg that was either lengthened or shortened compared to how it was prior to surgery. Once again, none of them lasted as long as we wished, and about 3% of them failed early, again within about 2 years, due to poor muscle imbalance or implant positioning that resulted in dislocation of the joint. Here, for instance, I'll illustrate what malposition components are. The x-ray on your left, if you look at the hemispherical component that we call the acetabular cup, it should be lined up at about 45 degrees. Clearly you can see on the x-ray on the right, it's about 90 degrees. The cup is very flat, and what can happen with that, when the patient moves their hip around, the area just below the ball on the stem can impinge against the edge of the cup and cause dislocation. This is why malpositioning of the cups is such a problem that we needed to overcome from how we were doing things traditionally. So looking back to the early 2000s, which was about when I started my practice, we started to change the way we did total joint replacement. The goals at that time were for a minimally invasive surgery to do our operations through smaller incisions, thereby causing less soft tissue trauma and hopefully allowing our patients to return quicker to their activities, as well as using computers in our surgical procedures in order to better align the joint, better align the position of the implants, therefore improve range of motion. You know, it was about the late 1990s, the early 2000s where computers really became prevalent in our everyday use. Our kids would use them, and we would even use them in, for instance, balancing tires. And again, there's that word again, balancing, and this is why I particularly have shown this, because they use computers to make sure that our tires on our car were balanced. Now, what would happen if the tires on the car weren't well balanced? Well, clearly you would get irregular wear of the tire. You can see here on the left-hand side, the tread of the tire is completely worn away, while on the right-hand side, the tire looks relatively new. That's because the alignment was not correct and the tire wasn't well balanced. Well, believe it or not, the same thing would happen with knee replacement surgery. You can see here that there's a crack in that polyethylene or plastic on the left-hand side. That happened because it wasn't well balanced and there was more stresses on that side. And believe it or not only could the plastic break, but the metal underneath it could break. And this occurs by a phenomenon called fatigue wear. And I always explain this to my patients. When we were kids, we'd take coat hangers and we move them back and forth in our fingers like this, and eventually they would break. What happens is the metal fatigues and eventually it breaks. So where were computers used in total joint replacement? They were used in total knee replacement to help align the components and balance the soft tissues. And they were used in total hip replacement in order to make sure the leg lengths were equal, the offset or the distance that the hip was away from the center of the hip was restored, and that the implants were positioned well. Interestingly enough, computers were also used then and are still used in spine surgery to make sure that the spine surgeons get those screws that they put in when they do fusions in the right place, because clearly the spinal cord runs very close, and the results of not putting it in the right place can be catastrophic. So it was around this time that we began using what we called computer navigation in the operating room to assist us with getting our implants in the right place. Here's a schematic of the operating room on the left there. It shows a patient on the operating table with a camera that has the patient in the surgical field of the camera, and a monitor which would show things like you see on the right, where we would mark out the joint and mark out the alignment that we wanted to achieve on the joint. The goal, as I mentioned earlier, of computer navigation was to minimize the outliers in terms of balancing the joint. Now this x-ray here, the red line that's drawn shows a line that is drawn between the center of the hip and the center of the ankle. This is what's called the mechanical axis of the limb. Ideally, for a knee to work well, a knee replacement to work well, and for the knee to be balanced, that red line should pass directly through the center of the knee. That would mean that all forces that are passing through the leg when you're standing on that leg and swinging your other leg during the walking cycle would pass directly through there and not more on one side or on the other side. If that red line passed more to the middle of the knee, to the middle of the patient's body on the left-hand side of the knee replacement, you would get more stresses through that side, which again would cause wear because the knee wasn't balanced. Now this graph shows how well we did with standard instrumentation versus navigated instrumentation. The darker bars show standard instrumentation, while the white bars show what navigated. Clearly the majority of them were within plus or minus 1 degree. But when I say that we wanted to use navigation to eliminate the outliers, you can see that with standard instrumentation, we sometimes had knees that were plus or minus 7 degrees from where we wanted them to be, which is a significant amount and caused the knee to be unbalanced. These are some of the instruments or trays that we would use for navigation-assisted total knee replacement. We would have a computer monitor with a program that was set up. We would place these, what we called arrays, into the bone above and below the knee, and then we would take a pointer where we could readily identify some of the anatomical points of the knee in order to give some of this information to the computer. We would end up with graphs that looked like this to show where the points were, and then ultimately we would see where we were going to make our cuts based on the plan that we had made, and we could do things like release some of the tissues, or in fact even change the position of where we were going to make our cuts. Like this, you can see that we changed them so that they're now almost overlapping and they're parallel to each other, so we can take more or less bone off in order to balance the knee better. Here's an implant that's being placed during surgery, and there's the final implant with the plastic and a well-balanced knee done utilizing computer-assisted navigation. So from the early part of this century, the emphasis went to MIS surgery, which was shorter incisions, which was felt to benefit patients and give them a faster recovery, and also computer navigation, which we felt gave long-term benefits. They allowed the implants to last better and function better throughout the life of the implant. So with regards to where we are now, I really think that in total joint replacement, what's going to happen in the future is here now. And the goals of that are to allow for faster recovery, again with less pain, and increased longevity of the implant. Now the natural progression from computer-assisted surgery, where we would map out the knee and then manually place cutting blocks to cut through, was to go to robotic-assisted surgery, where a robot is assisting the surgeon in making the cuts to make sure they're cut per the plan. So one of the things that we often find when we're trying to get authorization for this is that a lot of the insurance companies out there think that this is still experimental surgery. It's not. There are now multiple papers that are written on this, multiple presentations at large orthopedic meetings talking about the benefits of robotic-assisted surgery. And if, for instance, you were to come to see me and we were to sign you up for robotic-assisted hip replacement surgery, and your insurance company were to not deny it, we would be able to fight that in order to see whether we could get the authorization for you to have that procedure. So the most used system on the market is called the Mako Robotic Total Joint Replacement System, and it's a Stryker product, and it has 3 applications in that you can use it for total knee replacement, total hip replacement, as well as partial knee replacement. We have a series of workflows and step-throughs that we have to do when we do the operation. The only thing that the patient has to go through that's different from the other 2 techniques is a CT scan that has to be done prior to surgery. We plan this off of the CT scan because the CT scan gives us a 3D representation of what the patient's joint looks like, where an X-ray is only 2D representation. We can position the implants through some standard measurements at the beginning. Intraoperatively, we then take some measurements after we've again placed the arrays. We can then compare those to where the patient's actual anatomy is when we place some stresses on the joint. We can change those, and ultimately, the bone preparation or the cutting of the bone is done by the robot. So the pillars of robotic-assisted joint replacement surgery are enhanced planning. As I mentioned, we utilize 3D imaging with a CT scan, dynamic joint balancing. The surgeon can make very minor adjustments to the preoperative plan intraoperatively in order to get the joint well balanced, and then the robot itself, under the guidance of the surgeon, actually makes the cut. Now, I tell my patients when they come to see me in the office that the best way to describe this is to look at my hand as being your knee and looking at my other hand as being the saw blade. When we're away from the knee, the saw blade can move up and down in many directions, but as we get closer to the knee, it locks in. There's very little variance from where we've planned, and it allows us to cut exactly per our plan. There's much less instrumentation that's used in this because we don't have to use cutting blocks or guides or rods that we pass up and down the bone. Here's the preoperative plan that literally tells us within a 0.5 millimeter how much bone we're going to be resecting from the various parts of the knee, and also at what rotational angle we're going to place these at. Here's the operating room setup where the surgeon stands on the same side of the robot with the assistant helping them, and on the opposite side you see the camera and the monitor that the surgeon works off of. Again, we balance the joint. We're trying to get equal measurements on the medial and lateral side of the joint. Here you can see on the schematic on the left-hand side that those numbers are at 18 millimeters. The reason that we want that is that represents the amount of metal and plastic that we're going to place into the space that we cut in order when we do the joint replacement, and ideally we want to make sure that we're not placing 18 millimeters of metal and plastic into a 16 millimeter gap, because all that would do would be create tightness and imbalance. We can also balance the knee inflection to again make sure those numbers are corrected. We can adjust the position of the implants up or down in order to make sure those numbers are equal in flexion and extension, as well as on both sides of the joint. And here you can see the actual bony preparation. If you look at the upper left picture, there is no guide hold on that bone or being fastened to the bone. The saw is making the cut based on the computer program which we see just below it, and also the other 2 pictures show that on cutting the tibia. The final analysis, once we put in our trial implants, before we put in our real implants, we can make sure that we can take the knee through the range of motion, that the knee is well balanced throughout range. And then ultimately what we do is we put in the definitive prosthesis. Now, what I said earlier about this no longer being experimental, as I stated, there are a number of studies that are now in the orthopedic literature as well as presented at orthopedic meetings that show the benefits of this. And it's an interesting fact that once robots get introduced to any form of manufacturing, whether it be furniture, whether it be cars, whatever industry you want to talk about in which robots have been introduced, they have never been taken out. So robots, I feel, are definitely here to stay, and that's why I believe that robotic assisted surgery, the future is in fact now. Now that brings me back to the question that I asked at the very beginning of my talk. Who is the only character in Star Wars to appear in all of the movies? So I know that you can't tell me out loud or anything like that, so I'm just going to give you the answer. The answer, of course, is this individual right here, who of course is a robot. Thank you very much for your attention, and we can open this up to some questions now.
Okay, our first question is, what are your thoughts on PRP and stem cell treatment of osteoarthritis instead of total joint replacement?
PRP and stem cell treatment does play a role. The problem is you have to catch the arthritis early enough in the sort of progression of the disease in order for it to be effective. Once you get complete erosion of the cartilage from the bone to the point that there's deformity in the joint, I don't believe that PRP or stem cells work.
Okay, and what is the recovery time of a partial knee replacement compared to a total knee replacement?
You know, in general, the recovery time is slightly less. I tell my patients that with total knee replacement, they should be back to most of their activities somewhere around 6 to 12 weeks after surgery. And with a partial knee replacement, it's usually closer to 4 to 6 weeks after. The reason for that is there's less soft tissue dissection, less bony work that's done at the time of a partial knee replacement than there is at a total knee replacement. And in general, people can move about their business and their lives much quicker.
Okay, and how do I know if I need a partial or total knee replacement?
Well, you would come to that conclusion in consultation with your surgeon. If your x-rays showed that you had arthritic changes in all 3 compartments of the knee, clearly you're not a good candidate for a partial knee replacement. The other thing that I like to do, the most common partial knee replacement that we perform as orthopedic surgeons is the medial unicompartmental arthroplasty. That's the joint that's on the inside of the knee or closer to the midline of the patient. And so I'll often get patients that will come in and they'll have x-rays that will show that that joint space is collapsed, but they may have some minor changes in the other parts of the knee. I always ask them what I call the one finger test. I say, point with one finger and tell me where the majority of your pain is. If the patient then takes their hand and wraps it around their knee and said, oh, my pain is all over my knee, in general, they're not a good candidate for a partial knee replacement. If, however, they take their finger and they point to the inner side of the knee and they say, my pain is right here, then in my mind, they're usually a better candidate for a partial knee replacement.
Okay, and is there any chance of hardware rejection in joint replacement?
So hardware rejection is extremely rare. Usually when a person is diagnosed with hardware rejection, it's some type of low-grade infection that's actually going on. There are, however, a subset of people who primarily have nickel allergy, and we always ask our patients whether they have problems with costume jewelry, like when they were younger and they wore earrings that were not made of sterling silver or not made of gold posts or what have you, whether they had a reaction in the skin around it or sometimes from watch bands, whether they have a reaction. That's usually because of the nickel that's in the costume jewelry. So if someone does say that they have that, we usually send them for nickel allergy testing, and we're also able to test for multiple other metal alloys that could be in the joint replacement itself, and we can make a decision based on that. But true rejection of the joint of the joint replacement, prosthesis, as I mentioned earlier, is extremely rare.
Is hip resurfacing effective?
Well, that depends who you talk to. So hip resurfacing was originally introduced in the United Kingdom probably about 15 or 20 years ago. And there are still a certain subset of surgeons who perform it. Now, what happened probably around 2008 or 2009 is that many of the other orthopedic companies started to introduce hip resurfacing appliances into this country. And they didn't do very well, to the point that most surgeons don't use them anymore. And the reason for that is we probably had surgeons who weren't necessarily doing enough primary hip replacements with standard prostheses to be facile enough with the operation to do hip resurfacing arthroplasty. I think that now hip resurfacing arthroplasty does have a role in some young patients, but beyond that, the results that we're getting with some of the newer technologies that we're using that I just mentioned, and although I mentioned it for the knee, we do use it in the hip as well, would not warrant doing hip resurfacing arthroplasty in the majority of patients, as in fact, total joint replacement does as good or a better job and tends to last longer.
And do you go anterior or posterior in the hips?
I do my hip replacements from a direct anterior approach, which in my hands is the least invasive way to do hip replacement surgery, although I know that there's a number of my partners here at the Core Institute that use a posterior approach. Now, the posterior approach that my colleagues are using now is completely different than the posterior approach that I was trained with, and that's a result of this minimally invasive surgery that I mentioned that sort of started to come to fruition in the beginning part of this century. So not only were we trying to do things through smaller incisions, but in order to be able to do that, we needed to change the instruments that we were using and the retractors that we were using. We needed to make the shape different. We needed to make them narrower so they didn't get in the surgeon's way. And I know that there's a number of my colleagues that use sort of a very minimally invasive approach using a posterior approach, and where they don't take down as much of the muscle as, for instance, I was trained to do 20 years ago, and the results are good. In my hands, I think the direct anterior approach is the approach of choice.
Our next question is, what are options if you are reactive to nickel?
There are nickel-free implants that are out there right now. There's only one company that makes it, and it could not be used with the robot, but there are definitely implants out there that can be used. The majority of metal that's in an implant is titanium. Now, it's not pure titanium, it's an alloy that's made out with some aluminum and some nickel. There's a very, very small amount of nickel that's used, but again, in general, if you presented to my practice and told me that you had had trouble with costume jewelry or watch bands or so on, I would send you for the testing. If it came back that you were nickel allergic, then we would do the joint replacement without utilizing an implant that had nickel in it. And again, we would use more of the traditional instrumentation that I discussed in that part of the talk earlier.
Okay, and if I'm not a candidate for knee replacement due to health, what are my other options?
There's some of the non-operative things that I did discuss. There's activity modification, there's utilizing walking aids, medications, injections, weight loss. Those are some of the options that we would have in people who were in people who were medically unable to have joint replacement surgery. Another thing that's out there on the market that we can use is what's called an unloading brace. So for instance, if you're bow-legged and the arthritis is on the inner side of the knee, then we can put a brace on that sort of will manipulate your leg so that you don't bear as much forces through that part of the joint. The problem with those braces is that they tend to be very big and cumbersome. Patients don't like wearing them, and they are expensive.
After a successful knee replacement, how frequently should one visit the surgeon?
So within the first year of surgery, I like to see my patients generally, if they're doing well, 3 times. We see everybody at 2 weeks, at which time we inspect the wound and take out any sutures or staples that need to be removed. We see people again at 2 months, and people are generally doing very well at that point, and we tell them that we'll see them again at 1 year, always with the caveat that if they have any questions or concerns or problems, we're always there for them to come back and see us. People who aren't doing quite as well at 2 months, I'll have them come back again at 4 months, and then everybody comes back at a year. And then early on, I really think that it's important to see people every couple of years up until about the 7th or 8th year after surgery, and then I see them every year. And it's a very quick appointment. You come in, you get an x-ray. We look at the x-ray and make sure that the plastic component's not wearing or that there's no evidence that the implants are loosening. I think it's important to do that because if we can catch someone, for instance, where they're starting to show irregular wear of the plastic, can often do a revision surgery where all we need to do is go in and exchange the plastic. However, if the plastic is worn to the point that the metal has broken, like in the slide that I showed you, well, clearly at that point in time, you need to do more than just replace the plastic.
Okay, and how much range of motion can I expect to get back with hip surgery?
With all joint replacement surgery, the number one determinant of postoperative range of motion is preoperative range of motion. So it's much easier to describe in the knee. If someone has about 100 or 110 degrees of knee flexion, because they've got bone spurs that are formed in the back of the knee, or they've got a lot of scarring of the joint capsule, that's about what they can expect. Remember, when we go in there, we try not to take out as much of that capsular stuff as or the scar tissue, because it does perform an important function. So the number one determinant of postoperative range of motion is preoperative range of motion. As it applies to the hip, I tell most patients that they will get back about 120 degrees of bend, enough rotation that they should be able to pick up their foot and put it on the opposite knee when they're sitting in order to, for instance, wash or put on their socks or shoes. In terms of rotating the leg outward in the other direction, probably only about 10 or 20 degrees of rotation there, because it's really not an important motion that we need for everyday function.
What's done first, knee or hip, with severe osteoarthritis in both joints?
The hip is the joint that should be treated first. What goes on in the hip can often affect the knee much more than what goes on in the knee can affect the hip. And there's an embryological reason for that. When we first start off in utero developing into beings, we start off from basically 2 cells and then a bunch of cells. And what happens is the limb buds and the limb bud of the lower extremity, the knee actually grows out through the hip. So you can have people, I mean, if you've got severe arthritis that shows changes radiographically on both joints, it's usually easier to do the hip first. But if there's only mild changes in the knee, it's surprising that by just performing a hip replacement, you can often eliminate much or some of the knee pain that patient is experiencing.
If you need both hips replaced, how long between surgeries?
In my practice, I usually wait 4 or 5 weeks between hip replacement surgeries. I do the same on the knee.
Can cancer treatment like chemo and radiation degrade the implant?
It should not degrade the implant. It can, if you were to have radiation done to the area where the implant is, it's possible it can degrade the bond that's created after surgery between the implant and the bone, but it shouldn't actually degrade the implant itself. The implant's inert, it's made of metal, and the plastic and radiation or chemotherapy or whatever treatment you're having should have no effect on the implant itself. Well, thank you very much, everybody, for your time tonight, and I hope everybody has an enjoyable evening and stay safe out there.
Thank you very much for participating in the seminar this evening. If you will please take a moment to complete the short poll on your screen, we would greatly appreciate it, and we look forward to hearing your feedback.